Deep Medicine, your new book, and it is extraordinary. I'm going to hold it as tightly as I can so they can get a close shot on this. All right. It's the two takeaways that I have are one, the one that might be expected, which is AI is going to change everything in medicine. The second takeaway was much more surprising, which is that you're optimistic about it. And your argument is that it will actually, the AI tools that we'll have will give actually more time for doctor-patient interaction, more time for humanity, more time for doctors to practice old type of medicine.
Right. Well, that's really the key. I think the more short-term story is, as you say, the augmentation of performance, accuracy, speed, lessening costs of care. But the bigger picture is if we can really work on getting this gift of time, right, the decompression, the liberation of keyboards, and the getting rid of data clerk functions of doctors and clinicians, and all the other things that make their lives easier, at the same time giving patients their data, algorithmic support, and so further decompressing the role of doctors. So all that effort can then get us to what we've been missing for decades now, which is the true care in healthcare.
So I think you make a really compelling case for this in the book, but what's surprising about it is that the progression of medicine with more and more technology has taken us here, where the average doctor visit is now 11 minutes. And even that, most of it is spent looking at a screen or filling out EHR, electronic health records. So why do we think it's going to change this time?
Well, that's my biggest fear, Cliff, is that if we don't take an activist role and we just let administrators continue the squeeze, which has put us to the peak burnout and depression among clinicians in history.
Right.
If we don't do that, and if we don't use this time to turn back inwards, then we will have further squeeze and things could actually get worse. So now's the time to take this remarkable improvement that we can extract out of the world of deep learning, right, with all this data, which no human being could actually really assimilate all of it. And now we can really rev up that accuracy and get rid of so many errors, which is a big problem. But that's not the real story. I mean, the one that I think is possible, that's transformative, but will require tremendous amount of effort. It won't happen. The default mode will be things will get worse.
So, I mean, you talk a lot about this sort of augmenting of human intelligence here. We've heard that phrase a lot, augmented intelligence. But when you describe it, you're saying things like radiologists will have, AI, deep learning algorithms will review, thousands of radiological images and then flag ones that humans will look at afterwards. There'll be all sorts of warning systems that AI will flag, and then real human doctors will come in and make the evaluation.
Yeah, I think the key point there is we have to fess up about how bad things are now. That is, radiologists have a false negative rate of 32%.
Wow.
Across all the different scans. That's a lot of missed findings, like pulmonary nodules. Gastroenterologists miss small diminutive polyps all the time, and that are just as precancerous as the bigger polyps. So all these things can be improved by deep learning and machine vision, and they already have been shown to. So it's just a matter of getting that into clinical validation. And even today, there's been a new FDA framework about that, so we don't lock algorithms, but we continually take advantage of their autodidactic quality. So that's really encouraging.
You write a lot about, you talk about deep diet, deep mental health, deep, across the board, you've looked at AI applications. What was the one that surprised you the most in your 3 years of research?
Yeah, well, it's interesting. The deep diet thing was I actually did the experiment where, having to record on your phone everything you eat and drink, your activity, your sleep, your medications, all this stuff, plus your microbiome stool specimen, and then a glucose sensor for 2 weeks. And I get this output based on an algorithm of thousands of people that was put together by the Weizmann Institute, Aaron Siegel and colleagues in Israel. And it was a big surprise because all these foods that I would never go near were the ones that got the A ratings, and the ones that were the things that I actually like got very poor ratings.
But you had a specific issue, which is kidney stones, and so there were like a diet. This wasn't just an exercise for you and an academic one. This was really affecting a very painful condition.
Yeah, well, see, that's the real point, is why we have to have algorithms that take in this multimodal input that is lots of information. So that particular work was done without knowledge of other pre-existing conditions.
Right.
And so when that output came, things that are high oxalate foods, which would be bad for somebody with kidney stones, wasn't even taken into account. But the point about all this is that we finally have the absolute proof that there's no diet for all people, that we have highly individualized response. Our glucose responds differently, each of us. Our triglycerides in the blood responds differently to the exact same food, the exact same amount, at the exact same time. So now that we know that, we're on the way with these deep learning, machine learning tools to be able to fashion a bespoke diet to promote health. We're not there yet, but we're getting there. But it means working on all the data that's available.
I'd love to get a question here in the audience. Anybody have something? Okay. What you bring up, this issue of everybody's so individualized. That raises this sort of challenge of if everyone is N of one, right? It's very, very expensive to sort of process, to progress in medicine the way we have without something like AI, without some preliminary vetting.
Yeah. Well, I think you have your handle on something that's really very important. We wouldn't be able to make these jumps, like the individualized diet, like the ability to quantify a state of mind for people with depression and mental health conditions, if it wasn't for these really extraordinary algorithms. So the ability to, the deep learning has insatiable appetite for data, whereas we humans have early satiety. So we have a situation now, we can finally take this multimodal data and work with it to understand things we never did before.
And we've got a question right up front. Yeah, you should just identify.
Sure. Hi, Eric. It's Amir, the guy with the early copy. Can you tell us what you're doing at your institute using AI? I know you're doing a lot of work there. What are you specifically doing yourself within your institute?
I couldn't.
With AI. You're working in your institute of Scripps?
Yes.
With AI. Can you talk about what you're specifically working on?
Oh, right, sure. Well, we have working in genomics to actually use deep learning to rev up the interpretation of genomes, to find which variants in a person's genome are actually connected to health and medical issues, and also with sensors. So we are a center of excellence for biosensors with NVIDIA, and we're using that to work with time series analysis of things like heart rhythm, glucose, and many other wearable sensors.
You talked in the book about deep medicine really being three different deeps. One is deep phenotyping, then deep learning, and then deep empathy. Talk a little bit about this deep phenotyping idea.
Right, so that's really getting all the different information about a person that you can to define their uniqueness, the medical essence. So it isn't just their genome sequence or their microbiome or their environmental that you can quantify features, but also their sensors, physiology, the scans for their anatomy, all their electronic records. When you have all that data and the corpus of the medical literature, you can do some amazing things like a virtual medical coach to promote your health. So deep phenotyping, again, involves not just today terabytes of data, but it's continuously being updated. And if we have that data and we use deep learning to process it, that's where we can get to this state of deep empathy, which is what is restoring that human connection that has been largely lost.
Academic researchers, you've gotten some phenomenal reviews in the Science Journal, Nature, The Lancet. So on the academic side, people have really applauded this. How are medical doctors, clinicians responding to this new thesis?
Well, I think it's good to have some circumspection, but what we need is some hope.
Right.
Right now, things are really not good. And so many people are not just burnt out, but are retiring early. It's very common for physicians to tell their kids, don't go into medicine. I mean, it's not a good scene. And, it's also, remember too, that with burnout, there's a doubling at least of medical errors. So it's a vicious cycle that just fosters more burnout and depression. So we've got to break that up. And so the people I speak to, I ask, well, do you have another idea how we're going to get out of this? And I haven't heard one yet. So it's reassuring that we have a path that if we work on it hard, we might get there.
Dr. Eric Topol, the book is Deep Medicine, and we'll be back with you just in a short minute, please.
Thanks.
Thank you. That was awesome.